My real question is, do we necessarily need technology enabled to obtain a good result? This is one of my earliest cases. This was done almost in 18, 1990. And these are her X-rays 30 years later. No technology, limited ranges of implants. This is an uncemented all polyethylene tibia and an uncemented femur. And this has stood the test of time in 30 years. So fundamentally, what did we do right? I think we followed the basic tenets of the surgical procedure. We balanced the gaps, restored the alignment, and got secure fixation. And really the only technology we used was common sense logic and some of the tips that were imparted to us by the giants of orthopedics. And the result really was a well-functioning knee 30 years after its implantation. If you look at the previous, or you've heard the previous two presentations, the one thing that stands out is the fact that there is really no consensus on what is the optimal alignment, what is the best methods of treatment. And when you review literature, you really find that just about every technology or lack of technology works well in good hands, in selective hands, as long as you understand what you're trying to do. So let's for a moment look at the preamble of the technology in specific reference to robotics. So Sharkey wrote this paper in 2002, revised this in 2013, and talked about results of early failure. The preamble at that point of time was that possibly the mechanical way of doing knees was failing because of fixation failures, instability, and malalignment. And this was somewhere ascribed to the fact that this was an option of poor surgery. But the question that we really need to ask is, does technology necessarily lead to better outcomes, and what has history taught us along the way? And does technology indeed play a role in a busy clinical practice? So when you look at robotics, it comes from the word robota, which means, believe it or not, forced labor. I didn't really realize this until I looked at this. And there are two types of the systems haptic and the autonomous. The earliest robotic system was the RoboDoc, and current systems utilize the haptic principles. Apart from the issue of cost, the challenge really is time engagement in high volume centers. So I'm not trying to sort of steal Gurva's thunder, but to just give a perspective that while robotics has grown considerably, particularly in the US, it's mainly accounted for 15% of the unicompartment surgery, and likely to improve even further. And I think if one looks at technology as a basic ingredient, I don't think one can run away from the fact that at least in the UK cohort, the unicompartment cohort, this seems to give us a better improvement than the conventional group and is possibly cost effective. I think the real issue of alignment in the unicompartment procedure is critical for its survival, and this can be extrapolated and expanded into the issue of the total knee arthroplasty. Suffice it to say that the current debate on what is the optimal and the ideal alignment leaves a lot to be desired. We subscribe to the mechanical alignment principle, and we believe that this is the gold standard by which all other comparisons need to be compared. So again, in terms of when we do a unicompartment replacement, I would concede that possibly there are advantages having technology, and in particular the robotic options. Again, when you look at literature, the alignment using the robotic system was certainly better than as compared to the conventional mechanical alignment. And when you go through literature, this is really the one thing that seems to crop up almost consistently. There is not enough evidence in literature as we talk today to indicate that whether it's the navigation or the PSI or the eye assist or indeed the robotics that have given us better alignment or better long-term outcomes compared to the mechanical alignment. How you do these in terms of revision of soft tissue releases remains a bone of contention. Different people do it differently. We do it the way that was advocated by John Insel and Chit Ranawat. We do a fairly wide posteromedial soft tissue release. In severe varus deformities, we do a inside out release on the lateral side. And at the end of our procedure, we aim for about a snug medial compartment and about 1 to 2 millimeters of laxity on the lateral side. This is our example of experience with the uni-compartment surgery. We've done almost 1,100 of these, and all of these are fixed bearing. And we've had unacceptable alignment in 4 of our cases. And after the first 20 or 25 cases, when we were still on the learning curve, our outliers reduced to less than 2%. When you look at the coronal malalignment, it is very clear that, again, in Sharkey's article in 2014, malalignment predisposes to failure. The real question is, what is an acceptable malalignment? And it's definitely not plus or minus 3 degrees. There are reports in literature, again, from Seth Parrott's and John Arjunsen's group, that patients with neutral alignment had a higher revision rate as compared to the neutral alignment. So I think the literature is all over the place. So truly, what are we aiming for? And if you look at technology, a snapshot, whether it was MIS, gender, navigation, PSI, the newer materials, instrumentation, neuroimplants, the one thing that has consistently stayed with us is the fact that the fundamental tenets of soft tissue surgery, soft tissue release is balancing a knees inflection and extension, converting that quadrangular gap to a rectangular gap, and balancing the knees, not only in flexion and extension, but through the arc of flexion, is pretty much the tenet of a long-term, well-balanced, satisfactory knee. So this is robotics. We've had some limited experience. We've had experience with the Navio, which we use from time to time, particularly in some difficult extra-articular situations. And this is a very interesting article that was written by Johan Bellemans. And how accurate is it? Well, there are people who feel that there's no difference in the overall coronal alignment, but gap balancing is better. There's no long-term data available on function or survivorship, but subjectively, a short-term evaluation, this was taken at 18 months, was somewhat better. So typically speaking, in the total knee arthroplasty scenario, there's no evidence to indicate that there is a worse outcome for the mechanical, and survivorship at 5 and 10 years, which is the longest survivorship reports in literature on the robotic cohort, seem to be comparable. Having said that, this definite bias, certainly in terms of the uni-compartment on the robotic front, certainly it seems to indicate that there is a better option. And again, when you look at more recent articles from 2018, the one standout feature is that longer follow-ups are needed before we can document that this is the way to go. The real wonderful editorial from Bob Booth and Jay Parvizi in 2019 in JOA, I think pretty much summarizes our whole technology scenario at the moment. The current survivorship of TK is 98% at 10 years, 95 at 20, and current technology must better this figure, indeed a high bar. So the promise of robotics is to reduce outliers entirely possible, but alignment and decision-making is paramount. And I think this pretty much summarizes the entire philosophy of the current status of technology, be it robotics or be it any other form. And what we really need to really understand is that over 15 years, navigated knees have not shown a clear superiority. So that is another version of technology which over the years has seen a gradual decline. On the other hand, when we do look at some of these technologies might help us, we have the introduction more recently in this, again in these robotic cohorts of augmented reality, virtual reality, and artificial intelligence. They are being discovered and worked on, but current applications struggle to deliver. The one thing that has helped us is recognizing risk factors, getting pain management, and these are aspects that need to be factored in for better outcomes. At the end of the day, what we really need to do is to do our procedures the way that works best in our hands. In our hands, this is the mechanical principles, mechanical alignment, soft tissue releases, as I described briefly earlier. And this again is an article from 2018. Based on current, recent, and emerging data, unreasonable to assume robotics is necessary for both UK and TK. Is robotics a marketing tool? I wouldn't like to sort of dwell on that, except to say that the promise of robotically executed TK is seductive. We have a lot of patients come and ask us for this option. But currently, at least in the evidence that is available to us in the English literature, there is no evidence that it outperforms a well-done total knee arthroplasty by a well-trained surgeon. And to prove the point, we would like to recommend that you follow techniques and not technology. This is now yet another patient. This is my longest surviving patient, uncemented TK, 31 years, where we used logic, common sense, and soft tissue balancing and no technology. So the jury is still out. Our survivorship at 20 years is about 93%. And again, when you look at some of the...
Dr. Rajgopal, excuse me. Yeah, we're just running short of time. Thank you.
Right, this is my last slide. This is my last slide.
Thank you.
So I'll leave the debate to whether you should use technology and robotics to my good friend Gurva, and I'd like to thank you for your attention.